is key as far as human development. And if you want to have, in terms of potential, future potential, then nutrition is key. And that's why you can see in terms of debt and what have you. Probably for those who have just joined, myself, I'm Ezekiel Mupere. I am a pediatrician and medical epidemiologist based at the College of Health Sciences. And I am the current chair for the Department of Pediatrics at the college. So, as you all may be aware, that malnutrition refers to deficiencies or excesses or imbalances in terms of one's intake or use of energy or nutrients. This is based on WHO 2020. And malnutrition can broadly be grouped into two conditions: under and over nutrition. My focus is a lot on children, and of course that's my basis of background in terms of specialty. And the undernutrition in children, we have stunting, which may be known to most of you. That is when a child is low in height for age, or in brief, a child has growth retardation. Then what we call wasting, or low in weight for height or weight for length. And a child or an individual may have with or without edema or swelling of both feet. When you put pressure on it, it is pitting in both feet. That's what we tend to call nutrition edema in children. And then underweight, that is low weight for age. Then the other nutrition aspect, what we call hidden hunger or micronutrient deficiencies or insufficiencies. This is lack of the important vitamins and minerals. These are very key, and we call it hidden hunger because a number of us who are in this platform, these are our biggest problem, but overtly it may not be seen. Then, of course, overweight, obesity, or diet-related non-communicable diseases, which most of you are already aware, such as heart, stroke, or diabetes, or cancer. They are all grouped under this. And this schema is showing you in terms of malnutrition, over and under is what I've been alluding to. And the overweight, or we have overnutrition, we have over and obesity. Then undernutrition, actually in the children, we have stunting, which I've already alluded to as chronic malnutrition. Then when we say wasting, we are referring to what we call acute malnutrition. And acute malnutrition is composed of both moderate and severe. And then micronutrient deficiency. And globally, this just shows the burden and the distribution as far as malnutrition. Both over and under, you can see that Africa and Asia bear the greatest share of all forms of malnutrition. These are in terms of millions as far as stunting, wasting, and overweight. But just to show these captions on this extreme right, Asia and Africa in terms of distribution. And in 2019, more than half of all the standard children under 5 lived in Asia, and 2 out of 5 lived in Africa. That's about stunting. And as far as wasting, more than 2/3 of all wasted children under 5 lived in Asia, and more than 1/4 in Africa. Then almost half of overweight children, they lived in Asia, and 1/4 in Africa. So you can see that both in terms of over and undernutrition, still the problems are in our setting. And in Uganda, if you are to, from the cumulative numbers from say January to December, over 8 million children become wasted. And this has important implications. And the nutrition, undernutrition, whatever, is not only for the under 5 or the children, but even the adolescent age group. So as many as half of all adolescent girls in some countries are stunted, and this has important implications during pregnancy and the time of delivery in terms of poor fetal outcomes. And then this ends up being a vicious cycle in terms of human development or in terms of prevention. So undernutrition and child mortality has important consequences, which most of you may be already aware. But to emphasize, like if you look at this as circular, we have important causes that are key in terms of death in children: pneumonia, perinatal newborn, 22%, pneumonia, malaria, measles, diarrhea, HIV/AIDS, and other causes. But the big underlying contributor, a child may be documented to have pneumonia as death, cause of death, but behind it, such a child have malnutrition. So over 54% of mortality in children is associated with malnutrition. And severe wasting is a major cause of death in our children with the complications. And so acute malnutrition, which I've already told you is both moderate and severe, often grows dramatically when there are emergencies. And this schema is just showing you the consequences, which I've already alluded to, in terms of increased disease or morbidity, poor wound healing, infections are increased, and several complications as far as severe malnutrition. And also recovery is slower. And this not only for children, but even in adults. So all this leads to increased death, treatment expenses, and increased length of stay in a hospital. And many times when physicians, they tend to focus a lot on, and they're forgetting that nutrition is key, therefore healing or recovery is to be faster. And all this, they lead to increased cost, poor quality of life. So short adults with low birth weight, stunting leads to low cognitive impairment, low economic development, increased costs. So this is now at a bigger population level about the impact of malnutrition. This schema is to demonstrate or show what are the key determinants, or it's a framework by UNICEF as far as how malnutrition in terms of in terms of causes, but also in terms of the intergeneration cycle. I'm still focusing here. So we have what you call the immediate causes. The immediate causes, those refer to the child or to the individual himself or herself in terms of intake or the disease that predispose that individual to malnutrition. And here, so in the children, when a child gets malaria, diarrhea, pneumonia, etc., all those predispose a child to undernutrition. Similarly, the infant feeding practices at home, or in terms of quantity, quality, frequency, all these will lead to, so that's why we call this immediate as far as this child, or the congenital conditions. Then the underlying we are referring to at the household level. So household food insecurity, inadequate foods, or care practices at the household level, or the environment in terms of sanitation and hygiene, or health services in terms of access. So all these predispose children, not only children, but even the adolescents and the young mothers to poor or suboptimal nutrition. Then at population level, those are what we call the basic causes. This is about accessing services, financial or human resource issues, social cultural issues, economic and political context. These pose dramatic in a population level or in a community level. And when there are, of course, emergencies, these worsen in terms of contribution. And as I've already said, that in the life cycle, it ends up being, you have both short-term and long-term consequences, and you end up having a vicious cycle of this impacting on each generation comes. And these are very common problems particularly in our Busoga region. Of course, if you remove the Karamoja from the map of Uganda, then Busoga becomes #1 as far as these issues are concerned, and particularly malnutrition. So Having said that, just to give you a brief about biology of malnutrition. So we have over 40 nutrients that are essential to health. And if any one of these are deficient, then the person will not be healthy and will not be able to resist the disease. And this explains what we've just finished in the previous slides in terms of increased risk to infection and other complications. And all these nutrients are divided into two groups. We have what we call type 1 and type 2 nutrients. The type 1, for most of you are in the medicine or in the medical field, type 1 iron, and I know most of us, even mothers or whatever, all of us know iron, iodine, vitamin A, D, E, K, etc. So these are what we call type 1 nutrients as examples. These are they are stored in the body, and they reduce in concentration when there are deficiencies, and also they give overt signs on the body, but there is no growth failure as far as type 1 nutrients. And in the breast milk, these have been found to be very variable. They differ from time to time depending. So those are the type 1. In type 2 growth nutrients, we are referring partially potassium, magnesium, zinc, sodium, and so on. These have no body stores in the body. They are stable in terms of concentration when you ask the parts of the body to know in terms of levels, but they do not give specific signs in terms when one has deficiency as compared to type 1. And these are the key in terms of growth failure and the key determinant in terms of stunting. They are stable in the breast milk when you have to make acids and what have you. And this is just to show you cartoons of experiments. So this is what we've been explaining, that type 1, they will give you, when you are deficient, you will have overt signs, whether hair changes, you will have skin patches, both hypo and hyper, nails, brittleness, and so on, brittleness and hair, and so on. In terms of flag sign or hair changes, that is type 1. But type 2, you can see these are people, cartoons of the same age. But in type 2, you can see, as I've said, no overt signs, but stunting. Growth failure is the key dominant feature. And also these are to show you examples of rats and dogs, same age, but one deprived of type 1, sorry, type 2. And you can see how these rats or dogs became stunted or with growth failure. And this schema is showing you the same thing that I've explained in terms of differences when you're deficient. Type 1 or type 2, in terms of infection or signs such as anorexia, but also in general, when you are deficient in terms of starvation processes, in terms of reduced mass or body composition of fat, and eventually where the body ends up consuming itself in terms of reserve that may be present, and effect also on the homeostasis, and eventually complications, whether infection, whether overgrowth in terms of redundant muscles, And it's the same thing to explain what we call reductive adaptation. So particularly when children, many of you have seen children, when they become malnourished, they become slower, they become apathetic. These are the signs I was talking about: skin patches, whether hypo or hyper, body swelling, wasting. So the activity compared to the normal children is completely, and that's what we call reductive adaptation. So it's the physiological response of the body to undernutrition, that is, systems slow down. They do less in severe malnutrition in order to allow survival on the limited calories. So now that's the only ability so that the child can continue to live on. And of course, the obvious response is reduction in the body mass. And this affects all the systems in the body. So the whole body activity is low. All organs, the cardiac function, meaning the output, stroke volume, all these are reduced. the kidney functions or renal function, the filtration rate, the excretion, all these are reduced. The intestinal function, the gastric acid, the pancreas, the absorption, all these are affected, reduced. The liver functions, whether synthesis, metabolism, balances, all these are reduced. The muscle functions, skin, fat, glands, they atrophy or reduce in size in an effort of enabling this cell to continue hanging on. Even at the cellular level, the protein synthesis, the sodium potassium pump, most of you and whatever know the importance of all this at cellular level. So the permeability, the cells become leaky or permeable, increasing. So the intracellular sodium increases because the membranes that exchange, and the decreased potassium. And this is very important when we are managing these children. And that's why instead of giving, say, ORS, which is standard, we tend to give what we call Resomol. These are specially made ORS for children in malnutrition that have low levels of sodium and sustained potassium. The temperature regulation, all these are poor in a child who, in other words, that's why the child may have fever, but the temperature may be low, even below suboptimal, below 35, because of temperature regulation, which has been affected. All the immune functions are reduced in terms of response to infection, the glands, and that's why infection becomes the key. And that's why we generally treat all severe malnourished children with antibiotics, with the presumption that they already have in terms of infection. So all organs are involved and the system. So even when we are treating and managing them, we are cautious. We move slowly and cautiously, starting with mainly what we call a formula 75, where the calories are still low, so that we don't overwhelm the body. So who are the most affected or vulnerable? These are the boys or girls, children who are under 5, pregnant lactating women. That's why in pregnancy is key in terms of ensuring good, appropriate nutrition. Otherwise, that's why we are having at birth in our country, about 11 to 15% of our newborns are low birth weight, and nutrition is a key contributor to this. The elderly or chronically ill. In terms of geographical vulnerability, where there are floods, where there are droughts, that's why you see, or conflicts, that's why you see Karamoja is #1. You can see that almost every year they are reporting outbreaks of malnutrition or severe malnutrition to that. So also political vulnerability, or where there is discrimination or persecution. Just know that malnutrition is a big problem, and just know that in terms of cognitive performance is a problem. And the urban settings that have mushroomed now in our country, this is becoming a serious problem, that malnutrition in our urban setting is a big problem. And even the system, they need to be adjusted to see that we're also addressing nutritional issues in an urban setting. Where there are refugees, that's why Uganda is a big host for refugees. We have a huge problem of malnourished children or undernutrition in all these refugee settings in terms of vulnerability. This is just to explain what I've already alluded to in terms of growth failure, in terms of micro or micronutrients. What I've already explained is what we mean by acute malnutrition, thinniness with or without edema. This could be moderate or severe. Chronic malnutrition or shortness in terms of height or length, and also associated poor cognitive development. I've also alluded to acute and chronic, the underweight, when you have low weight for age, then the common micronutrient deficiencies in our environment. So in terms of steps of addressing, in terms of programming, we normally assess the situation, whether at facility level or community level. Then, of course, analysis, and then design appropriate actions or interventional strategies. These are just examples in Sudan where this is a big problem, or even in our refugee settings. So our country now have the nutrition information system in terms of collecting, analyzing, and interpreting reports through our health management information system. In terms of assessing which facility, which region, which district. So if this data is routinely looked through or followed up, we can now trigger or understand where the big problems are. Similarly, our every 5-year demographic surveys, then also there are smart surveys or LHUS that can be done. Of course, the clinical-based monitoring in clinical situations. Similarly, we are meant to be having school in terms of assessing this. And we tend to use MWAC is what we call mid-upper arm circumference, where we take measurements of the tip of the shoulder and the tip of the, and then the middle portion is that's why we refer to as mid-upper arm circumference. So there are also databases in terms of use, and as I've already told you that water, sanitation and hygiene, food security, health, all these are assessed when we're trying to understand the determinants and so on. So we definitely analyze indicators to assess the severity, in case there is an emergency in general, to see death, acute malnutrition, the disease, the morbidity of food security and livelihood indicators. And there are different frameworks in terms of the assessing this. And based on WHO, we have clear criteria in terms of what we can call acceptable, in terms of prevalence of wasting, where we use Z-scores, and once the Z-score is less than -2, and these are the proportions, acceptable, when we say it's poor, when we say it's serious, when we say it's critical, meaning the sunny emergency that food support, both the sick and the non-sick are needed. So we can analyze trends over time, the underlying causes, the relations between malnutrition and death, and also the seasonal variations, and then also in terms of predicting. And in terms of designing appropriate intervention, for simplicity, I would say we have what we call nutrition-specific interventions, and then nutrition-sensitive interventions. So most of the health-related issues, interventions like management of acute malnutrition in a facility, those are what we call nutrition-specific. Then aspects like water, sanitation, hygiene, those are what we are referring to as nutrition-sensitive intervention. This is the same, to explain the same, in particularly worse in emergencies. But I commonly say these are the same principles we apply, whether in chronic situations, whether in emergencies. So nutrition-specific, nutrition-sensitive. So the prevention, management of malnutrition, prevention or treatment of micronutrient deficiencies, infant and younger child feeding practices is what we are referring to as nutrition-specific. Then at household level, food insecurity, ensuring access to safe water, promotion, ensuring adequate access to health services, these are nutrition sensitive. In terms of prevention and management of acute malnutrition, the approaches we tend to use, one, there are 4 components. One is community mobilization and active case finding, where we even engage or involve community health workers, whom we refer to as VHTs in terms of training, where we also now involve even the households themselves. Then we establish what we call outpatient management of some severe acute malnutrition, so that children who are without complications are managed as outpatients, and then inpatient, those with complication, and then if these are emergencies or in refugee settings or in chronic food insecurity like Karamoja, we also institute what we call targeted supplementary feeding programs, and also what we call blanket supplementary feeding programs. This is to any household, regardless whether there is malnutrition or not, once there is such an emergency. So the common program is named as Community Management of Acute Malnutrition, abbreviated as CMAM. In our country, in our healthcare system, we named it as Integrated Management of Acute Malnutrition, so that it's integrated within the healthcare system, so that it's not a standalone in isolation, and it's integrated within the healthcare system. similarly, even in terms of reporting. So we, as I've already alluded to, that we have what we call therapeutic care. Therapeutic care is for the children who have severe acute malnutrition. And we categorize those with complication and those without complication. And those without complication, we treat them as outpatients. And then those who have complications are the ones we admit in health facilities. Then those with moderate malnutrition, what we give, we do supplementary feeding. In our country, or in our healthcare system, a lot of what we do is moderate malnutrition is treated as outpatient and mainly with the family foods and the health education and so on. But in situations like Karamoja, refugee, and so on, is where we add what we call supplementary feeding. And I've already alluded to what we call a blanket feeding, is where we give every household, but targeted are those with moderate malnutrition. Those are the children, pregnant, lactating women, adolescents, young. This is what I've already explained, which was endorsed by WHO in 2007. And these are the components that have already, and also we add on IYCF is infant and young child feeding, young. And this is what I've also already alluded to in terms of how we classify the acute malnutrition. I've already told you, we classify a child with normal nutrition, then a child with moderate malnutrition. And moderate malnutrition is any child when we take the weight for height or weight for length and the Z score are between -2 and the -3 Z scores, or the mid-upper arm circumference is between 11.5 and 12.5 centimeter. Those are children with moderate malnutrition. Even pregnant or adolescent, we have cutoffs for those as well. So we treat those as outpatient, mainly family nutrient rich in normal situations, but it's only in the chronic situations, Karamoja situations, is where we do supplementary feeding. Severe acute malnutrition without complications, and these are the cutoffs once they are less than -3 or less than 11.5 if it's MWAC, and they have edema, pitting edema of both feet. These and they have no complication. So we treat this as outpatient using ready-to-use therapeutic food. And UNICEF has been the key supplier for this, although local industries are also needed to sustainability. Those with complications are the ones we admit, the same cutoff, but they have complication. And I'm going to explain briefly in terms of what we mean by complication. So these, we treat them as inpatient, cautiously. The detail for how we do all this requires another session. So I'm not going to the detail of how we manage. That will be another session of how we manage during inpatient or outpatient. So in terms of the other component which I've told you about, community mobilization and active case finding, this is the community component to identify those who have acute malnutrition, whether moderate, whether severe, so that these are identified from the community and referred to the health facility for intervention. So this is what I've been saying, the mid-upper arm circumference is a measuring tape, color-coded, but so for community health workers, VHT, we train them with a color-coded tape so that they simply use the color, whether green, yellow, or red, and it is marked so that they can be able to, even now we are trying to empower mothers themselves to assess their own children. This is still ongoing in terms of trying to pilot how feasible this is. So mid-upper arm is used for children 6 to 59 months, and also pregnant, lactating, even the adolescents, young. So inpatient, as I've already said, all health facilities in terms of inpatient up to say health center 4, they're supposed to have a corner in terms of managing children with complications or infants. So as I've already been saying, we treat them cautiously, and the first phase, we call it stabilization, when we treat mainly complications with cautious feeding. Then and we use what we call the appetite. So we have a certain amount which we give to children based on their weight. If they complete that amount, once a child is classified as severe malnutrition, if he's able to complete, then we take that child as no complication. So then we can treat that child as an outpatient. But once the child is unable to complete that amount, then we treat that child as having complication as inpatient. So we, particularly the first 7 days is to stabilize. Then thereafter we transition. It may take some, it may vary, some may take 3 days, some may 4 days, but average around 3 to 7 days. Then we transition where we keep testing the appetite of this child, still using ready-to-use therapeutic food, what we are calling RUTF, is introduced cautiously, or formula 100, which has the same calories as ready-to-use. And once the child is able to complete a certain amount, then we gauge that the child is improving, recovering, and then we transition what we call the rehabilitation phase, where the child will begin watching in terms of catch-up, in terms of weight, or the edema reducing. In the first restabilization, we are not after weight gain, but we are after restabilizing the child. Then in outpatient, these are now children with appetite, so they keep coming every week. We give them a ration depending on their weight to use for a week, ready-to-use therapeutic food. And then we train the mother, we give them key messages in terms of managing this child at home. But also we keep this child on an antibiotic. As I've already told you, we assume any child with severe malnutrition to have complication. Then of course, documentation and ensuring all our child health conditions are interventions of prevention, vaccination, other medical care, and health education. But as I've already alluded to, that in the chronic conditions of food insecurity, refugee settings, and so on, then we institute supplementary feeding for moderate malnutrition, targeting the children, the malnourished, pregnant, lactating, and those at risk. And still, we use ready-to-use supplementary food, as compared to the other one, which was ready-to-use therapeutic. This one is just supplementing to the home diet or what the nutrient form have. Then blanket is when the situation is critical, we supplement, we give to blanket in terms of dry or wet rations of food to every household in that kind of situation. And that's why food distribution in emergencies, in Karamoja situations or refugee, these are some of when there was a recent outbreak emergency, this was done. And it can be wet or dry. And of course, we keep monitoring the global acute malnutrition. Then in terms of prevention of micronutrient deficiencies, we are promoting food supplementation products that are home fortified. That's why you see that most of the industries that are big now, they fortify whether the cereals and so on. Similarly, oils with vitamins and what have you. This is an effort of addressing the rampant micronutrient deficiencies that we have in the population. And also that's why supplementation during pregnancy, and that's why deworming and vitamin A in the under 5 is being done. This is an effort to address this. And in terms of in the nutrition cluster, micronutrient deficiencies will be able mainly provide supplementary feeding, home fortification, deworming, distribution, and promotion of recommended infant practices. Then it is other sectors like food production, agriculture, income and improving access to markets, fortification, nutrient rich. So you find that addressing nutrition issues is multi-sector. You can see we need all these sectors if we are to address some of these issues, in addition to only the health issues, interventions that we do. And I've already alluded to that in terms of homemade fortification, powders are being tried, supplement in terms particularly for children and other risky. Distribution of supplements, vitamin A, iron, folic acid, I've already alluded to this. Deworming, preschool, women, childbearing age. And then infant and younger child feeding, this is very key in terms of preventing malnutrition or preventing abbreviation. So how mothers or caregivers in terms of complementary feeding, once the child is 6 months plus, we encourage complementary feeding, handling milk products, all these become key skill which have to train the skill for our mothers in terms of how breastfeeding is done. And this is a huge problem. And that's why many children, infants end up getting suboptimal breastfeeding. Infant feeding, the concept of HIV, these are big problems when HIV has been on. All these are big components to be addressed in their separate sessions. Policy guideline and framework so that all these are embraced in terms of infant and younger child feeding, management of artificial feeding, these have become a big problem, particularly the middle income, particularly in urban settings whereby the formula, artificial whatevers are being marketed, all these negate the successes with breastfeeding. Orientation and training of health workers or providers is key so that communication, advocacy, all these are important. This is the same thing in terms of infant and young child feeding recommendation. That's why we emphasize early initiation of breastfeeding within the 1 hour after delivery. We emphasize exclusive breastfeeding for all children below 6 months. Then we start complementary feeding, and we encourage continued feeding thereafter, 2 years or beyond, and timely introduction of quality complementary foods from 6 months. I'll end here and say thank you very much. I had to rush through because of time. Over